Nick Majerison here. Welcome to TopMedTalk. Elderly patients and post-operative delirium. That's the subject of today's piece. It's a conversation taken from the ASA that occurred in Boston 2017, and it features Monty Mythen and Mike Grocott, joined by their guests Dr Brennan, President of the Royal College of Anaesthetists, and also Dr Gilder of Addenbrooke in Cambridge. And they talk about the importance of screening and risk mitigation regarding cognitive dysfunction and delirium in the perioperative period. It's got a particular focus, inevitably, on elderly patients. Have a listen.
In our discussions about perioperative medicine in the UK, we continue to discuss the baby boomers coming through and the number of elderly patients we're starting to look after, and frailty, dementia, all of those challenges. So delighted to be joined by one of your colleagues.
Yes,
right?
So Gilder, one of my colleagues from Cambridge. We live, both practice in a part of the country that's got one of the highest life expectancies in the whole of the UK. So we see an awful lot of our patients are in their late 80s, 90s and beyond, Faye.
We do indeed.
So Faye, thank you for joining us. So that delirium that's seen post-operatively, is that something that's just a little bit of the nuisance for the patient in the short term, the little bit of loss? Is it a serious longer term problem?
As I'm sure you know, first of all, its instance as a post-op complication in an elderly patient is between 20 and 60%, so it's the commonest post-operative complication. It's an independent predictor for increased length of stay. It's a potentiator. If you have any other complication, it's a potentiator of the impact, so it makes the impact of that complication worse. It predicts discharge to rehabilitation or nursing home, and also readmission. So in fact, it's a very serious complication, and it's something that we need to be addressing, I think, much more, or putting much more weight on back in the UK, and looking to what we can actually do about preventing it, because 40% of post-op delirium is preventable.
And preventable how?
Well, first of all, you have to find the at-risk patients. So number one, highlight your at-risk patients, and there's plenty of characteristics that predict your risk. Age greater than 65, type of surgery, abdominal, aortic surgery is particularly high risk, as I'm sure everyone's aware, orthopedic procedures, and indeed frailty. We can screen for frailty, and a lot of hospitals don't routinely screen for frailty, mainly because they don't know what to do with it. They know that you can screen, but then what do you do? But what you can then do is highlight the fact they're frail. You can recommend practices such that the patient is not anaesthetized in such a fashion that they actually are at risk of post-op delirium. And that means avoiding opiates, avoiding midazolam, trying to, again, use an EEG monitoring system to try and reduce the depth of anesthesia. There's many things you can do.
So, Faye, so one of my interests is prehabilitation, and this idea that you can improve physical resilience. Do you think there's something we can do to improve mental resilience using preparatory work?
So I have looked, I've been to the talks here, and I myself am quite interested in things like, can you give someone Sudoku for like 5 weeks beforehand? The jury's out, and the jury's also out as to whether you can make elderly people less frail. Really, you can actually improve their reserve. You can. I think for me, it's a theory of marginal gains. Stop them drinking. We know that if you get people sort of stopping drinking between 4 to 8 weeks pre-op, you can improve their immune response to surgery. Stop them smoking. Get them to do a little bit more activity. We know even in 4 weeks more activity, you can increase your anaerobic threshold as measured by cardiopulmonary exercise testing. So there's lots you can do. And I think if you pull all these things together, you can just improve their reserve to a stressful event. But there is another option, and that is to actually have a really long conversation with these patients about whether or not surgery is the right thing. And certainly the work we're doing in Cambridge, we're finding that 17% of our frail elderly patients presented to us, we're not going ahead with surgery. It's not the right thing for them when you actually have a proper look at the whole person.
So Liam, you've hinted at it, but from the Royal College of Anaesthetists perspective, is this a priority area overall?
Yep, I think it's a conversation we've been having in the UK now for some time. Shared decision making is something that we are familiar with. I think it is something, for various reasons in the USA, that it's where item of service is perhaps more of a driver, that it's something that's the conversation has been less focused about.
In making those decisions, in shared decision making, one of our podcasts earlier in the year from the perioperative medicine meeting in London, we heard from Angela Bader telling us that in around here in Boston, how many patients that they looked at in detail actually had no recollection of their consenting process afterwards. They had some cerebral dysfunction to a point whereby, as I understood it, Mike, am I remembering that correctly?
No, you are. That it was unclear that actually the consent process was valid.
So how does that person make informed consent?
I think that's a very interesting point, in fact, because some of the slides I've seen here have been around identifying cognitive patients who are cognitively frail, if you like, and they manage in their own life. They have a very regimented life, and you wouldn't necessarily detect it unless you seek it. And I think that is an enormous challenge, actually, trying to assure that they are able to make the decision. In our clinic, we do the animal numeracy test, which is a very sensitive test for picking up cognitive frailty. And in those patients, we spend more time with them. We really draw out the risks of things like postoperative delirium and post-op function, and have a conversation with the relatives in order to try and share that decision more. We also have our conversations with relatives present. And then giving them written information, so you're very, very clear and specific about what you've said. And again, we do give them they all get a copy of the letter that we send.
And the challenge, I think, for the health system in the UK, as well as it will be in the US and elsewhere, is adequate time to have those conversations. Yeah. That it shouldn't just be a point in time process of consent. It should be a continuum over a period of time, and also that the system rewards and remunerates for a situation where the patient in shared decision decides not to proceed with surgery. At the moment, there will be, even in the UK system, there will be precious little remuneration for a complex consultation that doesn't result in surgery.
Well, I think there's more to it than that. Currently, we really struggle with targets, referral to treatment pathways, where we're seeing, we're presented patients very late on in their pathway. You actually need time, as we've just discussed, to work them up, but also time to have those conversations and time to reflect on those conversations. And I think it would be enormously helpful if in some way or other we were able to stop the clock for certain groups of patients, where we can actually spend a little bit more time, working them up, because that in itself creates cost efficiencies, never mind anything else.
So I think that's an important point. Although you may not be directly remunerated for having the conversation, I think that the trusts and the commissioners are very receptive to the idea that actually, so by definition, many of the patients with whom you have a conversation and subsequently decide not to have surgery, part of the components of that discussion will be that they're high risk, therefore the patient's more likely to have complications, long stay in hospital. So it's probably, certainly in a bundled system as we have in the UK and as they're moving to in the US, it's probably in the financial interest of the system, as well as being civilised and humane, to pursue that strategy.
And one of the challenges is going to be how we train the workforce to have those conversations, because it isn't part of the training that people are currently receiving. We're about to have some workshops that are being held at the Royal College of Anaesthetists in London to do just this, workshops in training people to have shared decision-making discussions with their patients. So not the paternalistic approach put to one side. How do we work with you to make the best choices that you're going to make for your health?
So for those people listening, for those of us who aren't subspecialised in this field, what do you think are the most important things that we could practically do next week, next month, next year?
Screen for frailty, number one. Identify your frail patient, and with that recognise that with frailty comes the risk of complications, the risk of poor outcomes, and then have a conversation with the patient. You shouldn't just be screening for physical frailty, you should be also screening for cognitive frailty, and in fact I think possibly that's more important. And then the next thing is educate the workforce about delirium, because post-op delirium is probably the most damaging complication in this group of patients that we look after. It's certainly the most common and is association with very poor outcomes. Screening for delirium isn't difficult, and very, very simple non-pharmacological measures can actually stop it in its track. And as I've already said, 40% of post-op delirium can actually be avoided. So I think those are the three most simple things. Screen for it, talk to them, recognise and educate your workforce about delirium.
And the tools for screening, are they clearly defined, the best choices, or do you have a recommendation?
Well, in the UK, we either use the Edmonton Frail Scale or Rockwood's Clinical Frailty Scale. And the 4AT is what we're using for screening for delirium, and that's widely recognised as a useful tool, but there are others around as well.
TopMedTalk.
That's taken from a longer piece which you can find on our website, topmedtalk.com, recorded last year at the Boston ASA. Don't forget, of course, your opportunity to meet the TopMedTalk team is right before you. All you need to do is go online, ebpom.com, and you can find our events there. TopMedTalk, covering many of the conferences that EBPOM do. ebpom.org.